This is the National Aphasia Month, and so I thought we could talk about dementia. And this is a different format than we've used in the past. Usually I have a lecture and a PowerPoint and we talk about that, but people have been enjoying changing it up a little bit, and I've certainly learned stuff from the last few groups that have been here about dementia. I've got a few points I want to make sure that I get to, but mostly I want this to be a discussion back and forth about our clients with dementia, the problems we may have had managing their behavior, what we understand about dementia, and then hence, tips. What have you guys done?
Right.
So let's start. Remember, don't use anybody's name because we have to be careful about privacy of our clients. And nursing a family, we take that very seriously. So, but I know you are staffing a client with dementia that has very sensitive with odors. And so, how have you managed those issues? Lori, why don't you start? And describe the problem, and then tell us what you've done.
Well, one thing that I've done is I use sometimes distraction. I will acknowledge what's been said, and then I wouldn't say make light of it, but just really acknowledge that it's a problem, and yet it's not present. I just really name, as kindly as I can, a reality base, whatever can be offered and accepted by the person. And that sometimes work, or I get more adversity, it could happen. I will also, just change the subject, or just use that subject as an example in general and then move to that another subject. So make actually a bridging kind of conversation. So I won't discount the person or make them wrong, but I will, or a little bit engage in a light and playful way. That's another strategy also. So
Okay.
there's, yeah.
What do you know? What do you know about that?
Well, the lady that I work with has a problem with odors no matter whether there's odors or not.
All right.
So I assume probably a lot of that's in her head. And I was originally told when I started working here to just assure her that I don't have perfume on. We're all told not to wear perfume. And that works to a degree, but I do notice that she'll be very sarcastic and not really believe you. So I've kind of switched my strategy over the course of the year, and just to pretty much agree with her. And a lot of times it's true, I might smell something, and I'll say, the allergy season is here, and there's more things floating in the air, and that seems to work pretty good. She, as long as she seems to be able to be acknowledged, she just really wants to get her point across that she smells something.
Right.
And then once I acknowledge that, yes, I smell it too, and I don't know what it is, she doesn't know what it is, and maybe it's the air outside coming in, or the air inside going out, or whatever it may be.
You guys have mentioned a couple of really good things. The first one is validation, validating the person. Even though they have dementia, they still have the same suite of emotions that we do, and making sure that you're taking somebody seriously is really important. It's an issue of respect. Showing disrespect is going to escalate a situation that's already uncomfortable. The other thing is you mentioned, Lori, which is really important, is distraction. Now we know that especially early mid dementia, that short-term memory is what's affected most. Long-term memory tends to stay intact, and so if you're able to distract somebody, then you can get them to forget what they were worried about in the first place. That's a great way to manage other types of behaviors too, like aggressive behavior or hypersexual behavior, which is also present in some of our dementia clients. We have one client at an assisted living facility he's a big guy, so he can be intimidating, but he was like a Hemingway kind of guy. He's a big game hunter, and he's got zebra furniture, real zebra that he shot in his room there. And so when he would get aggressive or intimidating, the caregivers would just ask him about the animal head on the wall, and tell me how you killed that zebra. And so it would immediately engage him into another conversation. And then that gives them a chance to forget, that they were agitated in the first place, and it brings back, positive memories. So knowing who your client was and before they were sick is really important. So now you have something to talk with them about, right? We have one client that had been friends with the King of England, right?
Oh.
And so, you know, we engage him in that conversation every time. So he gets to share that wonderful experience in his life, you know, over and over again. So, you know, even after the event is over and he's forgotten you had that conversation, all those endorphins that are floating in his bloodstream making him feel good are still there. So, you know, we've improved the quality of his life. Any other, you know, difficult behaviors that you've seen? Andrea, I know you've worked with dementia before.
What I've used to distract patients, I had one particular client that was a lot bigger than I was,
Mm-hmm.
and he was very loud.
Mm-hmm.
And when it came to doing normal daily activities, brushing our teeth, combing our hair, getting dressed, he would get verbally combative.
Mm-hmm.
And one way that I figured out worked with him in particularly was to ask him why he was yelling at me.
Oh, yeah?
Why are you yelling at me? He would stop and go, well, I don't know. Like, okay.
Yeah.
Well, let's try to do this one instead.
Right.
And after a while, he'd get into the swing of things and he'd be okay with going along with what we had to do. And then we'd just get back to whatever started him off last.
Right.
Bathing used to be the biggest issue with him.
Bathing?
Bathing.
Good. I want to talk about that because we have, you know, the client you guys have now is having some hygiene issues. And so we need to come up with strategies to kind of help her stay healthy and clean. And so what did you do?
I would do special things for him, like I would ask him if he liked bubbles in the water, or I would use the special jet tub that we had there
Mm-hmm.
because it made him feel good. He'd get there and get to soak, and I would play music for him, the type of music that he'd like. I would designate it just that area for just him while I worked with him. We'd listen to music, and he would talk about his wife, and he would just kind of relax inside the tub for a while.
Great.
And that usually used to calm him down.
Yeah, it's important. And I have a story I want to share with you guys about bathing. So let me just share the story and then we'll talk about this strategy. So this is a true story. A gentleman in an institute, a memory unit, institutionalized for his dementia, who wouldn't take a bath. And it was affecting everybody, right? Because he wasn't smelling very good. And it wasn't healthy for him. But he used to be career military, right? And this is, once again, knowing who your clients were before they got sick is really important. And so the staff would tell him that the general was coming for an inspection and everyone needed to be shipshape, so you need to take a shower. And he'd go, yes, and he'd get in there and he'd take a shower. And so it looks, on the surface it seems like it's a little tricky, but it's important to know that people with dementia, they're missing parts of brain tissue. If you had, Lori, if you had severe dementia and I took your brain out and laid it in front of everybody and sawed it in half, you'd see huge holes there. So these folks are not going to learn anything new. They're not going to change their behavior because of you. So we have to change who we are and how we manage them in the outside world because we don't have holes in our brain yet, okay? And so that little tricky thing with him worked just fine. And it's not a lie, and it's fine to do that. So let me give you another, and you said something else that I thought was interesting. Playing music, right? So it's important, and Laura, you're a music therapist, so certainly this is important to you. Music is one of those things that often stays really intact in people that have severe dementia. And so all the types of music they used to enjoy, they still enjoy them. You know, so you can really communicate with somebody at a really deep level with music. And so what you did, there's a concept in one of our training videos about the 3 S's, right, with people with dementia. Stressors, soothers, and signs of trouble coming, okay? And so that's one of the key points I wanted to make sure I got to today. And so identifying what is a soother for our clients and tucking that away, you know, making a note about that, writing it in the chart so that everybody knows what a soother. Maybe it's music. We had one patient with dementia who was very difficult to manage her behavior, but she liked flowers and she liked colors. And so you take her to the florist and she would enjoy that experience a lot. And so knowing what the soothers are, and it's different for everybody. Like, you know, one of our dementia videos, it shows somebody with pretty advanced dementia getting into potting soil because he used to be a gardener and he liked that, right? And so there's a pot and there's soil and there's bulbs, and you may never get soil in a pot with a bulb in it, you know. But you can have this guy in there with his hands feeling and smelling the dirt. Those are pleasurable experiences. Those are soothing experiences. And once again, even after you know that experience is gone and he's forgotten it, he still has those endorphins floating around in his bloodstream. He still feels good. So soothers, finding out what those soothers are and tucking that away so you can use them. Stressors, finding out what those are so that you can put a soother in there to stop the stressor from being a stress. Maybe a stressor is taking a bath. You could have written that video because you did exactly what it said to do. Use a soother to ensure that the stressing event wasn't too stressful, right? A lot of our dementia clients have sundowners, all right? And that's when you go a little crazy as it gets to be evening, 5 p.m. or so. And so this one lady that loved colors, we knew at 5 o'clock she was going to be a behavior issue. And she liked the gardens, we had the gardening soil and stuff out there, but at 4:30, we'd get her out of the institution and take her to the rose garden, right? And she would enjoy the roses. And that whole sundowning thing just got skipped, right? And then signs of trouble coming, knowing your client, knowing when their behavior is indicating that they're about to get stressed out, might be repetitive motion of some type, that's important as well. Any other issues that you've had with dementia clients? Have you had any dementia clients yet, Ryan?
I pretty much just work with the one client that you were actually talking about that was friends with the King and Queen of England. And
Right.
that was the thing I would do to get him distracted. Was,
Right.
oh yeah, tell me about when you were dancing with the Queen of England and all that. Yeah. But I mean, his issue more than anything, he doesn't have like severe dementia, but he's mostly blind and mostly deaf. So communicating and trying to get, you know, the distractions and all that across is a little bit more difficult. But generally speaking, he doesn't cause like too many problems. It's more just the communication is the...
Well, one of the things that Lena Kay was telling us about him a couple days ago is that he likes to wash dishes.
Yeah, exactly. And a lot of the times I'll wash dishes and then 45 minutes after I wash dishes and we're done eating and all that, I'll just be like, oh, I need to wash dishes. And I'm like, well, it's done.
Yeah.
Then they're wet there, so I'm like, oh, do you want to just hand them to me and I'll dry them and put them away? He's like, oh yeah, that's great. And it just makes him happy and just go sit down.
It's okay if he washes a clean plate.
Yeah, exactly.
It's completely fine, so let him do that.
Bring them to my house.
Yeah, exactly. What was I going to say about that? Oh, I want to talk a little bit about aphasia, because aphasia occurs with severe dementia. Aphasia means, there's a couple different kinds of aphasia. Aphasia means you can't communicate. So expressive aphasia means that you're unable to say words properly or write your communication. Receptive aphasia means you can't understand what someone is saying to you. And so it's important with people with aphasia. Aphasia mostly is caused by strokes, but people with dementia have that as well. So there are a few keys to communicating with someone that has aphasia. One is what you were saying, get down in front of them so he can see you, right?
Exactly.
And make sure that you have their attention before you start talking. Make sure distracting noise is gone. You don't have like the radio blaring or things like that. And try communicating simply, like maybe they can't speak, but they can point. Which hat? Point to the hat you want to wear today, and they can point. And that's effective. He's effectively communicating now. So I wanted to make sure I had a chance to say that. The other thing I wanted to say is that it reminded me of a story. But when we talk about stressors and stuff like that, there was a true story of this gentleman on a memory unit that was, he would be weeping all the time, crying and weeping all the time. And the staff didn't know how to manage it. And so they brought a dementia expert in to check on him. And sure enough, he was there in his room, and he was in a corner in a fetal position just crying. And she asked him, what happened just before this? And the staff said, he asks us like he does 20 times a day where his wife is, and we have to remind him that she's dead. Right? And so he forgets that his wife is dead, and he forgets that he just found out again. So 20 times a day, this poor guy found out his wife was dead. Oh my God, how horrible is that? And so she went in to sit with him, and he got more calm while she was sitting with him. And then he asked her, have you seen my wife? And she said, yes, I saw her. She was out walking in the garden. She should be here soon. Tell me about your wife. And he brightened up, and he talked about his wife and this wonderful relationship. Once again, that's not a lie. right? That's managing somebody with dementia, right? So
Big difference. Yeah.
it's a huge difference, right? And so we're trying to anticipate, what's going to stress our clients out. We're trying to know what's going to soothe them, and sometimes we use these tricks, like, hey, the general's coming for inspection. You need to get clean. I need you guys to put your heads together with that one client about how we can help her with her hygiene issues. Any thoughts on that right now?
I need to be updated about how it's
Okay.
going. Yeah.
She's
so-
not bathing, and she's not letting anyone in her room to clean her up.
Okay.
The rest of the house is clean.
Okay.
Do you have any ideas?
This is a really difficult situation because her bathroom is inside of her bedroom,
Mm-hmm.
and she always keeps the bedroom door shut. She won't let you go in there.
Mm-hmm.
And when I'm there in the morning, she comes out of her room already dressed with her purse in her hand, ready to go eat breakfast.
Mm-hmm.
So there's no way to have her take a shower in the morning.
Okay.
An alternative would perhaps be to get her to bathe in the evening.
Okay.
But I haven't tried that yet, so I don't know how
Okay.
it would work.
Is she defiant when it comes to?
She's fight about everything.
Yeah.
You know this person. And so it's difficult. I mean, you're trying to. So if we weren't staffing her, she'd be in a memory unit, locked memory unit right now, which
Right.
might not be the worst thing in the world, but not what she wants. And so we're trying to, value her independence and her, her right to make her own decisions as safely as we can. And we've been creating that safe environment for her. And so we just recently, clearly the medication issue was horrible. She was squirreling her medications away. They were in piles, and it was dangerous. And so we took that away from her. Now we control the medications. Right?
Yeah, she still tries. She'll palm a few pills and try to get by you into the bedroom.
No, I know. And but this is a safety issue. You have to see her take it.
Right,
And you say, Dr. Nelson has ordered me to watch you take this medication.
right. What's worked for me is the fact that she wants me out of the kitchen.
Mm-hmm.
And so I'll tell her, I'll be glad to leave the kitchen as soon as I
Yeah.
see you take your pills.
Yeah.
Deal.
Yeah, so she hurry up and takes them so that I'll leave, So
Okay.
that works pretty good.
So that's the pills. I mean, we now have positive control of that. But
She still wants the pill box in the kitchen, though. That was an issue this last time.
it's in your room now, right?
Oh, yeah.
Yeah, good. That's too bad that she wants it in the kitchen. It's
Yeah.
not going to happen. So we still have to think about the hygiene issue. So you were thinking maybe trying at night.
Yeah, because a lot of times she'll say goodnight to me 3 or 4 times.
Yeah.
And once in a while she'll come into the room with her robe on.
Mm-hmm.
So maybe I could convince her, to take a shower or something before she goes to bed. But I still would have no way of knowing if she really did or not,
Okay.
if she doesn't come out again.
When was the last known shower or bath?
I have no idea.
We don't really know.
Wow.
Right.
I have tried, like accompany me, not to the shower, but I tell her, I'm going to brush my teeth, have you done yours? And she said, no, I'm going as well. So if I go to have a shower, I have told her, I'm going to have a shower, what about you?
Okay.
And I try to
Okay.
fish like this way, maybe she's thinking, oh, it's time, maybe it starts to work in this way because she's coming to brush her teeth while I'm going
Yeah.
to her bedroom, of course, to her bathroom.
Yeah.
But it is like a little invite.
I like that idea. So
Yes.
you're going to
I
do it.
see.
So would you like to brush your teeth too? Let's try that.
Yes.
And let's try to communicate when you've discovered what's effective. Make sure you call me, and then you write it in the medical record. We keep the medical record in the house, so write it there. Any other issues? We're about wrapped up. Any other behavior issues you guys have seen, or issues or questions you have about dementia that we can talk about? One thing I wanted to talk about is just the on a microscopic level, what the cause of dementia is, just so you know. So this is dead brain tissue, all right? So these folks are not going to learn anything new. So you have to modify your behavior because you don't have dead brain tissue. And the reason they have dead, there are over 100 forms of dementia. The most common is Alzheimer's dementia. But there are other types like multi-infarct dementia where you have tiny little strokes and so you kill off pieces of the brain that way. But Alzheimer's dementia is the most common type of dementia, and we're going to see a lot more of this as the baby boomers age. You know, there's going to be a huge epidemic of dementia in this country. But the way Alzheimer's works is that the individual cells die, and so the way a brain cells work. So say you're a brain cell and I'm a brain cell, okay, and I want to communicate to you. I've got this long tail called an axon that comes up to your cell body. And I create neurotransmitters in my cell body, and then I transport them, like serotonin or norepinephrine, and I transport them down this long tube to the synapse, which is a space right here, and I release those neurotransmitters into that space, and that excites you. Okay? Exactly, good. We're good at this. And the way those neurotransmitters get transported down that long axon is through a microtubule. It's like a garden hose, right? And the garden hose is made up of protein. It's called a tau protein. And the way proteins work, all proteins work because of their three-dimensional structure. So a protein factory is called a ribosome. And it attaches an amino acid, and then another amino acid, and another amino acid, and it spits out this series of amino acids. And as it comes out of the ribosome, it starts to fold into different shapes. There's alpha helices, there's beta-pleated sheets. Ultimately, there's a three-dimensional shape to this protein. And so enzymes are proteins, and the way enzymes work is that they have like a lock and key sort of mechanism. You can bring two chemicals together to hook them up. What the enzyme does is connects this chemical here, and this chemical is really close to it till they lock up. It's very simple. But the tau protein is what's creating this microtubule. So you've got a tau protein, and a tau protein, and a tau protein, and a tau protein, just like that. So you've got this long microtubule that neurotransmitters can be transported down. Tau protein in Alzheimer's is folded wrong. Okay, it just came out of the ribosome wrong, right? And so the microtubule doesn't work, which leads to cell death, right? So that's what's happening at the very microscopic level. On the macroscopic level, there's holes in the brain. There's holes in the brain, and it's irreversible and progressive and ultimately fatal. There are some medications you can use to slow it down. And there are some activities you can use, like brain activities. Dancing is protective in dementia. And so keeping people engaged, keeping them with conversation, stimulating their mind, getting them physically to be active as well. Those are things that will slow this down. But at the end of the day, it's progressive and fatal. All right?
Right.
So unless there's anything else that you guys want to talk about today, I think that's it. I really appreciate you being here. Thanks for helping me learn something. Yes.
I have kind of question, which
Sure.
is not, my patient is more kind of psychological, but it's little, what we were talking about quite close, and I really am very interested. My client has absolutely normal brain conditions and no dementia, but she's sick, and she get kind of seriously sick a year and a half ago, and before that, even though she's getting in couple of days 83, she was very spoiled with her good active body and good health. As I find out, she was riding horses and walking a lot, and was very active.
She's depressed. She's depressed.
Yes, she's depressed. Yes. But we are very well get along, and I make her laugh, and she has little problem with hearing, but I find the way with my accent to entertain her when she can't understand what I say. If she thinks always it is her hearing problem, so I'm making it more obvious that it's my English and this kind of. So everything is fine, but when I have kind of myself psychological problems, when she, in the morning especially, she's very depressed, and she asks, Ketevan, I never get back to my shape, I never get better, right? And I always kind of, first time it was harder, but then I have this energy to tell her, no, don't say this. I believe, I have intuition. I'm not doctor, but I have intuition. I have this feeling, and look, 2 days you were so good. Yes, but last week I was, well, you know, it's like spiral, and I go this kind of, we can call it blah, 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 I don't know. But we were talking about what is lie and what is not lie. And she's not stupid, she's a smart woman, and I don't want her to distrust me.
Right.
I don't want to overdo it.
Right. The,
Excuse me, one more detail. And her husband, who is also this incredible man, but he's probably, of course, also depressed with great sense of humanity. Sometimes he tells her, well, it's our age, we are going downhill, and it's like knife into my heart. But at the same time, I'm thinking, I don't know, is that right what I'm doing or wrong in big picture?
Well,
that moment, it's kind of works.
couple things. One is, you know, you guys are all highly functional caregivers. And so when you took that psychological evaluation before you came here, we look at that. And if you weren't tuned internally to do a good job at caregiving, you wouldn't be sitting at this table right now. Most people don't pass that test. You guys all pass the test just fine. So it's good to trust your heart. But it's also, with someone that doesn't have dementia, misleading that person is a lie. But so this is what you do. It's something called active listening, right? She's trying to process what's happening to her body. You're not going to stop what's happening to her body. And she is going to get older. And so she's, just like when we have hospice patients and they're dying, and they want to talk about stuff, you know, you don't tell them, you know, maybe you just try one more time. Because they have to process dying. You know, that takes some time. And she has to process her body giving out on her. And so you do something called active listening. So if she says, Ketavan, you know, am I ever going to get any better? You can say, you're worried you're not going to get any better, aren't you? Why don't you tell me about that? Right? You just kind of say back to the person what they said to you with different words. And you don't have to fill silence with words. You can just stop and wait and let them say the next thing. And she would say, you know, I get so depressed because my leg hurts so much. And you can say, you're feeling depressed about your leg, aren't you? And that does several things. It gives them a chance to explore whatever that issue is, and they're validated. They got heard. Someone heard them say something, and they said it back to them. So I would encourage you to do active listening.
Okay.
Okay. Anything else, guys? All right. Thank you very much. Appreciate you being here.